Started. Yes. Okay, recording. All right, hi everyone. This is our respiratory lab. We are going to go through our respiratory models that you will see by picture with stickies on it, or you will see by picture from your book for our upcoming lab exam. All right, so the respiratory tract, we are going to assign the nasal passageway to this tract. So you can look at this in these half heads, or you can look at this in the big models, anywhere that you see the nasal passageways. So let's first talk about borders, all right? Borders. So anterior border, what would this be? The entryway is these holes, what are they called? Nostrils, all right? Superior border, if you don't remember, it's where, again, your olfactory bulb is pushing down. It's your ethmoid bone and your cribriform plate of the ethmoid bone, okay? A little bit of the frontal bone up here, and this is your frontal sinus, and then here is your sphenoid bone, so this would make the sphenoid sinus. Okay, so those are kind of your upper borders. Remember, your smell is tied into the ethmoid bone. The olfactory bulb is sitting right here. And then those first order neurons are pushing down. All right, inferior border is your hard and soft palate, right? And then the posterior is just the opening here. Sometimes you'll see openings called fauces, like F-A-U-C-E-S-E-S, okay? And then you'll see the one of our tonsils, our adenoid tonsils, is kind of sitting right there. And remember that the eustachian tube connecting to your middle ear ends and comes in about here, okay? Now, inside, it shows these three bumps. So remember the three protrusions or bones pushing in. So those are the nasal conchae, and some of them are independent bones, some of them are part of the ethmoid bone and some of the other bones, okay? So you have a superior, a middle, and an inferior conchae, and then a tunnel created by the bone, just like the tunnel created in your ear canal. These are known as your nasal meatuses, okay? So if I put the brackets here and I ask, what are these features? You can say either or. It's the nasal conchae for the protrusion, or you can say those are the nasal meatuses for the tunneling. They serve as a speed bump to slow air down, and then they're pushing in for the respiratory mucus here, the mucosa layer of stratified squamous, non-keratinized, goblet cell rich slime, to be able to start purifying and pulling particles out of the air. And if they can pull the particles out of the air, then the air that leaves and enters in the next part is the pharynx. That air is a little more purified. Okay? All right, pharynx. The area of the pharynx directly, behind the nasal passageway, nasal pharynx. The area behind the oral buccal cavity, oral pharynx, and then the area right here near the larynx is the larynal pharynx, okay? All right, you need to read the question because there's three parts. I could ask you, give me the three parts from inferior to superior order, or give me the parts from superior to inferior order. So read the question and know which order they go into, okay? The pharynx is going to be one of our organs that's in both the respiratory and the digestive tract, okay? Now, when we get to this part here, okay, so if you ever watch TV shows, when they go to put someone they put a tube in their mouth when they stop breathing, they'll lay them on their back, and they'll try to go through the mouth, and they'll try to stick the tube down on top of their tongue, and then they'll push upward, push towards their, anterior throat. What they're trying to do is get the tube into the trachea, okay? The flap that sits here is your epiglottis. So if we transition to our, again, larynx model, so this is sitting kind of towards the anterior. Behind it is the esophagus, all right? This little piece of elastic cartilage, that's your epiglottis, okay? This bone, which sits kind of in front of the vertebra and is kind of free floating, it's not attached to any other bones. This is your hyoid bone. So it's one of those bones that has no direct contact with any other bones. And if you look on your skeletons, it's kind of attached towards the front in the neck area, okay? All right. Food's gonna get, or air, this is to keep food out, this is to keep water out. So this piece of cartilage has to be elastic for the lifetime of your life. Because every time you swallow, and we'll learn, you swallow something like 24,000 times a day, this thing has to cover the entranceway into the larynx and the trachea so that you don't end up with liquid sitting in your lungs. And remember, your lungs are warm. There's some mucousy material, so there's fuel. And if any kind of, like your inner ear, if any kind of bacteria is to get into that warm environment and sit in water, it can just propagate and grow, okay? And so that's part of the reason why we want the epiglottis to cover every time we swallow, okay? All right, tonsils. So going back to our half head here, you know that you need to know your tonsils on here because of their role in the respiratory tract. Just remember that most of the time those are going to be asked per the little girl picture in your, but you can see one right there. All right, let's go over, histology. So again, most of the histology in our nasal passageway, because it's so close to the opening is going to be a stratified squamous, non-keratinized. There will be areas where there might be some pseudostratified ciliated columnar, okay? But mostly it's close to an entranceway. It's a high risk area for pathogens to try to come in. So it's gonna have a little bit more robust layering to it to keep pathogens from getting into our system. All right, larynx. Big piece of cartilage here. This is your thyroid cartilage. The little bat-looking cartilage here is your cricoid cartilage, okay? This is the Adam's apple. So this cartilage, again, cartilage changes with hormones, with puberty, with growth. Remember we learned about the bones kind of ossify. So with guys, this is why in the puberty, it grows and it elongates and it forms their Adam's apple. And what else happens is some of the cartilage back here, the adenoid cartilage and corner-cuate cartilage, that changes and it connects to the vocal cords and the vocal folds. And that's why the boy's voice drops and changes, okay? Because all of that testosterone is causing, again, the cartilage to rearrange and grow and change its malleability, okay? The ligaments will be connecting cartilage to bone or cartilage to cartilage. And most of the ligaments you're gonna label are gonna get their name because of what they're connecting. So if you remember, like the acromioclavicle ligament connected the acromion and the clavicle will be the same thing. So the coracoid and thyroid, so that'll be the coracothyroid ligament, okay? All right. Again, you do need to know the little, there's like a little line there. I don't know if you can see it. So that's the difference between the adenoid and corner-cuate cartilage, okay? Okay, when you look in the vocal, again, vocal cords and vocal folds, our models are not great for that, so don't worry about trying to be a vocal cord and fold expert. But the opening created between them in this model, that's known as your glottis, all right? And again, the nuances of being able to manipulate that opening a little bit, a lot, the malleability of what vibrations you can create, that has the big effect on people having the ability to like that sing that wide range, you know, have that wide range of notes. Just like anything with age, it gets less malleable, it gets less, you know, less control and more stiff. So that's why you don't see 50 and 60 and 70-year-old sopranos, right? Because if those old sopranos tried to sing, it sounds way more shrill than what it used to, okay? Okay, so going into the trachea, these are the tracheal cartilage, and these are, again, the ligaments that are gonna connect the cartilage, right? If we pull out I gotta take this off. I'm sweating now. Whew. All right. If we pull out from our models, you can see again the trachea. You can see that trachealis muscle, and some of you have this in front of you. All right. And then you see the esophagus back there. And for histological purposes, we expect that in here, the innermost lining is pseudostratified ciliated columnar. All right. Trachealis is a little bit of smooth muscle. There is some of the neck, the epiglottis, that is some skeletal under your control muscle. Swallowing, you initiate it with voluntary control, but by the time things get into the trachea and the esophagus, it's involuntary. Okay, that's why coughing and things like that, that's involuntary. Okay, right? And then what we'll learn in the esophagus is we have, again, our mucosa layer, our submucosa layer. Our smooth muscle is our muscularis layer, and then the outside will be the adventitia because it's not in the abdominal pelvic cavity yet, it's in the thoracic cavity. Okay. All right, landmarks. The fork here is the carnea, and then these first two branches, so taking the trachea and the air into the right lung and the left lung, these are your primary bronchi. Okay. Now, for your shape of the cartilage, don't get caught up in if it's C-shaped or U-shaped. That muscle there, that trachealis muscle, it is the ability to tighten it up and make it more of a C, or dilate and let it be more of a U. And that little bit of manipulation is how we can potentially dilate that muscle and open the airway a little bit more, so we can get a little bit more air into the trachea, and then that would lead more air into the primary, secondary, tertiary, so on and so forth bronchi. Or we can try to tighten it up. Now remember, connective tissue, connective tissue, connective tissue, connective tissue between the pseudostratified ciliated cells.
No, get down.
All right? Anywhere in connective tissue, there can be mast cells, there can be neutrophils, there can be eosinophils, there can be macrophages, there can be immune cells capable of spitting out cytokines, and cytokines can change the trachealis muscle, constrict it. Cytokines can change blood flow, so to make the mucousy more, more leakage out if it dilates and brings more capillary filtration pressure, or if it constricts arterioles, then it can make everything really dry. Okay, so there is everything that inflammation, changes from the immune system can happen in this airway. All right. And when it's very, very, very reactive to particulates, to mold, to grasses, potentially inducing asthma, it doesn't always have to induce asthma, but those are particularly reactive airways. And those folks might have to always avoid their triggers because it can make it more difficult to move the air, respiratory ventilations per minute that they're moving across the mouth, and or make it more difficult for how much air is actually getting to the alveoli. Okay? All right. So you need to know landmarks. You need to know histology. All right? And there is a histology picture that has this in your book and in your lab manual. So be prepared for potentially asking about both the esophagus and or trachea together in a station. Okay? Now, when we get to primary bronchi, there's one to the right, one to the left. In the left, it's going to divide into two secondary bronchi because we only have two lobes in our left lungs. The secondary bronchi on the right are going to divide into a three because there's three lobes. And then what'll keep happening is you'll keep seeing forks and forks and forks. And then you start adding so secondary, tertiary, quaternary, and then you keep going with whatever the number is for that appropriate word. Okay, somewhere around, let's say 2 to the 12th, 2 to the 14th, the cartilage is going to go away, and you are going to then, I don't know if it's on here, you are going to see that the tubing becomes just the pseudostratified ciliated cells, areolar connective tissue, and a little bit of smooth muscle. When there's no more cartilage, you're left with, that's the bronchioles, okay? And usually people who have really, really bad triggered asthmatic, they have to have their drug of sympathetic agonists, so something like norepinephrine, epinephrine, that they have to shoot into their system to get to those bronchi to cause them to dilate. Because they're constricting, because their body thinks the ragweed, the pollen, the whatever grass or dust they've inhaled, the dander from the dog, is a super deadly pathogen and is trying to close up all the access to the alveoli so the pathogen can't get in the blood supply. And if it continues to do that, it could potentially kill the person because they're not getting, if they're not getting air in, they're not getting oxygen in. Okay? And so once we establish that, okay, dust is not going to kill you, open up those airways, you know, avoid the dust so you don't keep having the mast cells and every other immune cell spitting out their histamine and their, you know, factors. But that's part of what is going on. And again, smooth muscle, for the most part, in the cardiovascular system, we thought of sympathetics, we thought constriction. Smooth muscle in the respiratory tract, sympathetics means dilation. Because if you're running away, I want to get more air and more oxygen into my system. Okay? All right. Next model would be our lungs. So everybody should have some lungs in or around them. Okay? So again, lungs coming out of my model. Some of my borders of my lungs will have maybe one or two names. So the top is the apex. The bottom is the base. Another name for the base is also known as the diaphragmatic border. Because the anterior is closest to the ribs and the costal cartilage in the sternum, the anterior border is also sometimes called the costal border because it's near the costal cartilage. I don't think the pack has a name, or if it does, we don't talk about it a lot. Okay? All right. They make it pretty simple. So this is a right lung, 3 lobes. So it has a superior, a middle, and an inferior. The fissure that cuts it in an angle is the oblique. The one that cuts it directly, you know, like side to side, that's your horizontal. Okay? The entry point. So everything comes into the lungs at one entry point. Same thing will kind of happen later on. We'll see everything comes in and out of the liver at one entry point. For the spleen, everything comes, I don't know if you can see, in and out at one entry point. So the term that we tend to call that, all right, is the hilus. And if we want to talk about one of them, we can say the hilli or hilum, because it's kind of Latin. Okay, so this would be the right lung's hilum. The left one would be over here. And what you can see coming in and out is those bronchi, pulmonary vein, arteries, which are blue because they're carrying the deoxygenated blood. Pulmonary arteries, which are red. I mean, pulmonary veins, oh, I'm messing it up. Pulmonary veins are red. Pulmonary arteries are blue. Okay? All right, and then over here in this one, they also show you there's some yellow in there and green. So we know that blood vessels go in, capillaries are going to go in, capillaries leak. The green is going to represent some of the lymphatics that are going to pull some of that excess fluid out. And the yellow represents nerves. There will be stretch receptors in here. There will be feedback mechanisms that are neurologically tied to our breathing centers, to our autonomic, sympathetic, parasympathetic outflow. Okay? So on this guy, again, you'll have the costal, apex, base. You have this indentation and curve, so it's known as your cardiac notch. You only have 2 lobes, so you have a superior and an inferior lobe and just the oblique fissure. Okay? Sometimes they'll talk about when you roll people, you always want to roll them on their left side because the right lobe is, or the right lung is bigger. And if you're rolling them to the left and fluid then could potentially accumulate with gravity on this here, you're leaving more right lung potentially available for air gas exchange. Sometimes you'll see that or you'll hear that's why you want to, when you roll people into a recovery position, roll them onto their left side. Yeah.
Go again.
Okay. What did I miss? Oh, histology. All right. In the air sac, so in these alveoli, you are going to get capillaries and airways together. So you're going to see simple squamous epithelium, a little bit of areolar connective tissue. That's also sometimes known as the lamina propria. And then you're going to have the endothelial cells, which are simple squamous epithelium. And the distance you're trying to create in these alveolar air sacs is that air, which is where the oxygen, which is where the carbon dioxide is located, and the space to the blood plasma and the red blood cells is like at 5 microns. Now, there will be little areas where it kind of has gaps and has areas where it'll thicken up. In those thickened areas where the connective tissue is more robust, that'll be where your fibroblast lives. That'll be where your mast cells are, your lymphocytes are. Right? And so I think they call them pneumocytes type 1, pneumocytes type 2 for some of the different cells that can live in there. Right? Everything in this respiratory tract is humidified. So you have to take chemistry. Here's another reason why. Water molecules, when they get together, they form a certain kind of matrix of how they want to, for their polarities, they want to kind of organize themselves. And what they do is if we were to drop water right here, it would cause a droplet to form, and that droplet would kind of pull into itself, right? It doesn't spread out. So water molecules, when you put a bunch of, again, H2O, 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 and the way they orient themselves, they have surface tension, okay? So in your lungs, surface tension is part of why your lungs want to collapse in. All of these little air sacs are full of humid air. It's part of why the little air sacs want to collapse in, right? To break some of those water chemical bonds to kind of keep the air sac from like a balloon completely collapsing down, you are going to produce a kind of a soapy molecule known as surfactant. And surfactant's goal is, again, that those H2O, those polar and hydrogen bonds, try to break those up a little bit so the air sacs can stay a little bit more open. If you're going to work in the NICU, if you're going to be around premature babies, we know that surfactant production can happen somewhere between the 24th to even as late as like the 30, 31st, 32nd week of gestation. We know that babies born around the 24th week do have a small chance of survival. One of the biggest hurdles is going to be that respiratory distress syndrome, meaning when the baby takes its first breath, it doesn't have the ability to make surfactant yet. So all of that humid air in their alveoli are going to make all their alveoli collapse into small little cavities, and the amount of force and pressure, remember pressure gradients they have to create, it's so much they can't inflate their lungs. And so we'll have to ventilate them to keep their lungs working and get air and gas exchange and oxygen into the baby. We can make surfactant and try to give it to help, but again, we have to basically hope the baby's system kicks into gear and starts making its own surfactant for it to be able to potentially get off the ventilator and survive. So that's usually one of the big things that is talked about with surfactant and the importance of it. And any and every one of you that has any desire to be in a NICU unit, you're going to see this. And it's not always a happy outcome, okay? Yes, and actually on Tuesday, one of the students shared that she was born at the 24th, 25th week, and she's still alive to survive that. But that's, you know, not always the case because they're born at 1 to 2 pounds. And again, if they're not making that surfactant, they're not able to breathe on their own. For twins, you hear about twins are usually going to come around the 30th, 32nd, 33rd week. And because twins are both sharing everything, they can even that late in gestation, which is still early, be born and still potentially one of them might still have respiratory distress syndrome. Okay, and it relates back to the surfactant, and it relates back to surface tension. It relates back to chemistry, and that's why we torture you to make you take chemistry. Okay, and a little bit of physics. Okay. All right, the only other thing I think we haven't talked about is the pleural space. Okay, I'm gonna walk over here to get the model I forgot to get. I don't really love this model, so don't expect it to be on the lab, but expect this to be the picture for the pleural cavity, okay? So remember the pleural cavity, you're gonna have, if there's three of these things, so there's a light blue, a dark blue, and a brown. The pleural cavity, let's say, I don't know exactly what the model is supposed to be, but let's say it's this blue area, okay? That means the light blue would be the outer membrane, and the outer membrane would be our visceral pleural membrane. And remember the visceral pleural membrane, the inner part is going to be mesothelium or simple squamous epithelium. And then this will be connective tissue, and it'll be a little bit of areolar connective tissue really next to those mesothelial cells so capillaries can get in. And then it'll be a little bit of a dense irregular, because this is what potentially is going to connect into the periosteum, the perichondrium, the epimyocin, all the connective tissue. That's the outer border of the bone, of the cartilage, of the muscle, of the diaphragm, okay?
But listen.
And that is how, again, this connective tissue part, the parietal membrane, is kind of attached and pulls and moves with the ribs, with the cartilage, with the diaphragm, okay? Now, this cavity, remember, is going to be a very small space with a little bit of water. Water, that's surface tension. Water, you put two plastic bags next to each other with water, what do? They stick. Put two pieces of glass together with water in them, they stick. So the water in here is going to pull on this parietal membrane, pull a little bit on the ribs, pull a little bit on the muscle, pull a little bit on the cartilage. And by doing that, my rib cage is not as wide or as outward as it possibly could be. And it gives me room when my muscles contract to make it move a little bit outward because it's not already at its maximum. Okay, so that's one of the important things about the parietal membrane is it helps kind of keep everything, the rib cage, the muscles, the cartilage, it keeps everything pulled in a little bit. So when I need to make my lungs bigger, I have room to pull my chest cavity out. Okay, all right. The brown one is going to be our visceral pleural membrane. And it has a mesothelium, and then it has connective tissue, and that connective tissue is going to attach to the lungs. All right? And again, it is going to be tied into the lungs, and because the lungs have all the surface tension in each and every one of these air sacs trying to collapse them down, because in between is all of this elastic connective tissue, and what does elastic connective tissue stretched out want to do? Recoil in, all right? This visceral pleural membrane is tied to the parietal. The parietal wants to pull it out. The visceral wants to pull in. So this is a space where there again has pressure that is a little bit less than atmosphere and a little bit less than what is in the lungs. And because of this visceral membrane and the parietal membrane creating this little pressure negative space, that is why your lungs are a little bit inflated and not all the way deflated. Okay? And it lets your lungs and your chest sit in a place where I have a little bit of room to go out and I have a little bit of room to go down. And in that space, I can work on, and when I need to inhale more, I can. If I need to exhale more, I can, because I have that space. If I'm all the way extended, I can't go out anymore. I can't make any more inhale. If I'm all the way collapsed, it's very hard to exhale. It's very hard to make a pressure gradient to reinflate. Okay, so that's the importance. And again, these membranes, expect them by picture and expect to know mesothelium. And I heard that commercial, I think it was yesterday or last night. If you or anyone in your family has suffered from mesothelioma, call us today. Because again, if they're breathing in toxic things with asbestos, that asbestos could potentially get into this connective tissue space, could damage these mesothelial cells, triggering them to then become cancerous. And cancer doesn't have room in this chest cavity to grow out, so where is it going to grow? In, and if it grows in, do my lungs have as much space and have as much real estate to be where they need to be? No. And so my oxygen, air, gas exchange levels would go down. And eventually, if it gets big enough, I'll start to notice it with my pulse ox. Okay, guys, y'all are about to get kicked off. So if you have any questions, email me. I'll try to get this video up later today. Thank y'all for joining. I'm trying to see everybody's names. Okay, I think I'll remember those names. So questions, email me. I'll stick around for you guys and we'll go through it again if you want so we can slow it down. And don't forget you have 2 labs due this week, right? So you'll go through these again. You'll go through histology and you'll start going through some of the physiology of it. And then next week we'll do pulmonary function testing. Well, we won't actually do it, but we'll talk about what it's for and what the volumes and capacities mean. Okay, bye guys. I'll try to put the recording up later.